Good morning, everybody. For those of you who don't know me, I'm Claudius Marr. I'm one of the cardiologists here and the medical director of the ventricular assist device program. On behalf of the Department of Medicine and the Division of Cardiology, we would like to express our gratitude to Professor Sampson for supporting this visiting professorship. And we're honored and delighted to be able to have Dr. Keith Aaronson from University of Michigan as this year's Sampson visiting professor. Dr. Aaronson is an international leader in the field of advanced heart failure, mechanical support, and heart transplantation. And he's been the principal investigator on a vast number of really pivotal types of clinical trials that have moved our field forward. And he's the Bertram Pitt Professor of Medicine at University of Michigan and the medical director of the Advanced Heart Failure program there. And in addition to all of his PubMed searchable accomplishments and his really prolific career, he's also been a friend and mentor to many, many people in our field. So it's my distinct honor to introduce Professor Aaronson.
Thank you very much, You wanted me to move away from that. Thank you for that very generous introduction, and thank you all for inviting me here. I'm honored to be here, and particularly honored to be here for this professorship. I mentioned a couple of people that I read about Dr. Sampson at your life a few days ago, and to say humbled can't begin to express it. I know I won't recount your accomplishments because I know everybody here is well aware of them, but honestly, I can't help but being choked up thinking about what you've lived through, and it's truly inspirational. It really is. So I did have a couple of questions when I came here the other day. Skies were gray, and two things I couldn't figure out. One was why all the M's were upside down. That was really weird. And the other is how it is that I must have walked past a few hundred UW students, and nobody was carrying an umbrella. I was walking around, and I looked like, I might have just had a big T for tourist on my head. So are you made of Gore-Tex here? How does that work? I don't know how to get it. All right. I don't have any conflicts of interest to disclose. I will be talking about an experimental device, so I wanted to emphasize that I don't have any financial interest, intellectual interest, but no financial interest in the device at all. So cardiorenal syndrome is defined as a pathophysiologic disorder of the heart and kidneys whereby acute or chronic dysfunction of one leads to acute or chronic dysfunction of the other. And it's been divided into five types. We are going to focus on type 1. Type 2 is chronic abnormalities in cardiac function causing progressive and potentially permanent CKD. And certainly many of the patients we talk about will have underlying type 2 chronic cardiorenal syndrome. Type 1 is acute worsening of cardiac function leading to acute kidney injury. And in fact, about 60% of people who have type 1 acute cardiorenal syndrome have underlying chronic kidney disease at the time that they develop acute worsening kidney failure in the context of acute decompensated heart failure. So CKD is present in about a third of patients with chronic heart failure and is associated with increased mortality in both HFrEF and HFpEF. This is a study looking at quartiles of GFR in patients. This is a secondary analysis of PRIME2, a study of a drug ibopamine, which didn't work in heart failure. But what you see there is that as GFR drops, the likelihood of dying goes up. Whoops, wrong way. And this is looking at mortality risk as a function of both New York Heart Association class and GFR. And you see that increasing risk of dying as the New York Heart Association class goes up or heart failure gets worse, as well as an increased risk as the GFR drops to an even greater extent. And you see that these interact with each other. So there's been a number of meta-analyses looking at this. Worsening renal function, which is variously defined, which we'll get to in a bit, occurs in about a fifth to two-fifths of patients hospitalized for heart failure associated with increased mortality. And I mentioned that 60% of those have CKD. Damon has done two meta-analyses. There's actually a little bit better graphics for the first one, so I'll talk about that mainly. This is of 8 studies evaluating worsening renal function and all-cause mortality in heart failure samples. You see a whole lot of patients with pretty prolonged follow-up, both inpatients and outpatients. And here they characterize worsening renal function as class 1, 2, or 3, or mild, moderate, or severe. And you see the categories there, 0.2 to 0.3, or 5 to 10% decrease in GFR, 0.3 to 0.5 of creatinine, or 11 to 15, or greater than 0.5. Most of the studies that only look at one cutoff use 0.3, but you do have to look at how it's defined in the literature to understand what they're saying. So this is looking at people with moderate worsening renal function. Again, that's 0.3 to 0.5, 11 to 15 mil per minute per 1.73 meters squared. And you see a point estimate for the relative risk of 1.48. For class 3, 0.5, greater than 0.5, a very large increase of over 3-fold increase in mortality. And the increased risk that's associated with worsening renal function is not just in the short term, right? So here you see a best fit curve looking at hospital mortality, 1 month mortality, 6 months, and greater than 6 months. And while the risk does decline over time, it's still persistent. And I think, as we all know, that risk is a function of what the baseline serum creatinine is. So as serum creatinine goes up, the risk correspondingly goes up. So this was updated in 2014, now with over 1 million subjects in these studies. And again, very similar findings, all-cause mortality, odds ratio 2.3, worsening renal function, the same prevalence, really as I had mentioned before. So what's the relationship of hemodynamics to worsening renal function in acute decompensated heart failure? And this, this is painful, frankly, for those of us who work in end-stage heart failure, because there's a whole lot of stuff we do that there's incredibly scant evidence has any benefit. Now, the truth is, we all have anecdotes and individual patients that we've taken care of that we're absolutely convinced it's made a difference. I'm still convinced that there are people who we've put on temporary mechanical circulatory support of one kind or another that we've helped. And you'll, despite what I'm about to tell you, you won't convince me otherwise. But if you look at the studies, it is extremely difficult to show that. So this is 145 consecutive patients with HFrEF at the Cleveland Clinic who are admitted to their ICU with acute decompensated heart failure, wedge pressure greater than 18, or right atrial pressure greater than 8, index less than 2.4. Looked at the impact of baseline hemodynamics on the occurrence of worsening renal function. Here defined as rise of creatinine of 0.3 or greater. So, about 2/5 developed it and about 3/5 did not. So this is looking at quartiles of serum blood pressure. And what you can see is below each quartile of blood pressure, it's telling you, and the same is going to be on the graphs, the ones I show you next, the next 3. It shows you what the baseline creatinine was in those patients. So admission SBP was not associated with worsening renal function. One of the thoughts for worsening renal function is the renal perfusion gradient. And if you think of an input function as a function of systemic blood pressure and the resistance on the other side being central venous pressure, or central venous pressure is a surrogate, then one might think that as the pressure is lower, you'd have more worsening renal function. Not so. Admission wedge pressure was not associated with worsening renal function. Again, you see the creatinines were roughly the same as you went across. Now, admission cardiac index was associated with worsening renal function, but before you get too excited about that, and maybe the print's a little bit small, it's the higher cardiac index in this study that was associated with worsening renal function, not lower cardiac index. Now, it's important to note, though, that of these 145 patients, if you came in with acute decompensated heart failure with a cardiac index of 2 points of greater than 2.6, your creatinine was actually at baseline quite a bit higher, right? So part of the issue here is that the patients were not getting effectively diuresed, or I'm hypothesizing a resistance to trying to diurese them, or maybe an inability to because of underlying kidney dysfunction. Admission CVP, however, was strongly associated with worsening renal function, and you see that here. So CVP less than 8 in the lowest quartile, with less than 10% of people developing worsening renal function, whereas if your CVP was over 24, it was about close to 80%. Now, there's a secondary analysis of the ESCAPE trial that also shed some light on this. So ESCAPE was a randomized clinical trial, NIH funded, that was looking to see whether PA catheter guided therapy would lead to a reduction in days alive out of the hospital, and that failed. So the primary hypothesis was not shown to be true. Now, there was an improvement of cardiac index in the PA catheter arm. We don't know whether there was an improvement in the non-PA catheter arm because they weren't measuring it. There was in the PA catheter arm that was pretty substantial, about 30%, that was not associated with an improvement in renal function. There's multiple lines of evidence from this that hemodynamics volume status are not the sole or major driver of renal function in acute decompensated heart failure. So baseline renal function in this secondary analysis was not associated with any of these hemodynamic parameters listed, and worsening renal function was not associated with change in these parameters. And what about interventions that are designed to deal with them? So I said the one thing that was clear is that baseline CVP is associated in most studies with worsening renal function, although not in ESCAPE. So in the DOSE trial, they looked at, again, this was the Heart Failure Network, NIH funded. They looked at high versus low dose diuretic. And there was, in fact, more fluid and weight loss with high dose diuretic, but there was actually more worsening renal function when you took off more fluid. What about ultrafiltration? So no improvement in renal function with ultrafiltration versus loop diuretics in ADHF in the UNLOAD trial or rapid CHF trial, two moderate-sized studies that looked at ultrafiltration. And in CARES was a study of ultrafiltration. I'm having a hard time with that one. In which patients had both acute decompensated heart failure and worsening renal function at the time they were entered into the study. And there was, in fact, further worsening of renal function during hospitalization and 30 days after discharge in the patients who received ultrafiltration. So that didn't work. What about drug therapy to protect renal function in ADHF? So relapholin, which is a adenosine 1 receptor antagonist, failed to preserve renal function in this setting in the PROTECT trial. Nocirtide at low dose and dopamine at low dose, renal dose, no renal benefit in patients with ADHF and renal dysfunction in ROSE AHF. And tolvaptan, despite greater fluid loss and greater weight loss in the Everest study, was actually associated with a greater increase in serum creatinine. So none of that stuff's working. So this is a cartoon looking at things associated, looking at acute heart dysfunction or things that we do to people who have heart dysfunction and how that might impact on kidney injury, and a little bit of stuff going in the other direction as well. And I won't go through all of it because it's all stuff everybody knows, but I guess what I'll go back to say is that this stuff doesn't seem to make a whole lot of difference. We do know, I should mention, just for the sake of completeness, that what I haven't shown you here is a bunch of analyses showing that increased renal dysfunction in the course of initiation of ACE inhibitors is not in clinical trials or in the observational analyses associated with an increase in mortality. So, how much do you tolerate? Nobody knows the magic formula for that, but certainly nobody should leave here, and I don't think anybody would have, but nobody should leave here thinking that we don't want to try and give ACE inhibitors or some other, we'll talk, sacubitril, valsartan, or an ARB to patients with heart failure without a good reason. So down here we've got a cartoon, part of the cartoon talking about immune-mediated damage and how that immune-mediated damage leading to endothelial dysfunction could negatively interact both on the kidney and on the heart through monocyte activation and caspase activation. So we're going to talk a little bit more about that as we go forward. So inflammation in heart failure. So both HFrEF and HFpEF are associated with increased inflammation. In 1990, Milton Packer was smart enough to meet Beth Levine, one of the residents at Mount Sinai, and she had a lab and she could measure TNF, and she measured TNF and found that it was increased in people with HFrEF, and the smarter thing he did was then marry her. And then and here we are now in 2016, and there are a host of pro-inflammatory cytokines that are have been identified as markedly elevated in patients with heart failure, and plenty of work showing that elevations of these are associated with worse outcomes in patients with heart failure. So the cytokine hypothesis, which was put forward by Doug Mann, is that heart failure progresses, at least in part, as a result of the effects that are exerted by the innate immune system and endogenous cytokine cascades on the heart and on the peripheral circulation. And as I mentioned, elevations of these biomarkers are associated with worse outcomes. Further proposed that the purpose of the immune response is to resolve tissue injury and restore long-term function, but that a chronic inflammatory state of parainflammation exists in patients with heart failure, and that there's a graded response that may restore tissue homeostasis, and certainly maybe that's what we're seeing in patients who have myocarditis who resolve, but that also may result in further disease progression. So monocytes clearly play a central role in heart failure inflammation. There are three subsets of monocytes that are based on expression of cell surface markers, CD14 and CD16. The majority subset is the classical subset that expresses high levels of CD14, but no CD16. The intermediate subset, which is also pro-inflammatory and also expresses high levels of CD14, has some CD16, and the non-classical that does not has low levels of CD14, but a lot of CD16. So as I mentioned, the classical and intermediate are pro-inflammatory. The non-classical is anti-inflammatory and has reparative functions. Chronic heart failure, chronic kidney disease, diabetes have all been shown to have an increase in pro-inflammatory monocytes compared to normal controls. And this increase in inflammatory monocytes is associated both with worse clinical outcome and progressive development of atherosclerosis. Monocytes migrate into target organs and differentiate into both inflammatory and anti-inflammatory macrophages, and one of them too that stimulate, that trigger the adaptive immunity responses, Th1 and Th2. Now, in dilated cardiomyopathies, and there's evidence of this in ischemics as well, but more in dilated cardiomyopathies, more evidence. All types of infiltrating cells, TMB cells, granulocytes, macrophages are increased, but only T cells and especially macrophages are preferentially increased. And activated macrophages contribute to contractile dysfunction in heart failure, and there's evidence that this actually occurs through direct physical contact with macrophages and myocytes, at least in part dependent on increased INOS. So what about a strategy of anti-inflammatory therapy in heart failure? And at least to date, we don't have any evidence that that actually works. So Doug Mann did a series of studies. Actually, the guy who runs our EP program, O'Connell, actually did a bunch of those studies before he got misdirected and became an electrophysiologist. And showed that if you give TNF to dogs, you can recapitulate the heart failure syndrome. So studies with Etanercept, Renaissance, and Recover didn't show benefit. You see here a trend to increase mortality at a higher dose, no change at a lower dose. With Recover, no mortality change at either dose versus placebo. Both those studies were stopped prematurely for lack of benefit. Renewal was a combined analysis to look at mortality. In fact, showed no benefit on death and hospitalization. Infliximab in the ATTACH study, a smaller study, showed a strong trend to actually clinical worsening at a higher dose. There was a couple doses studied, and that was due to an increase in deaths and heart failure hospitalization. So that study stopped. And then there's a study called ACCLAIM that Guillermo Torriamione ran that was kind of novel. They and not entirely clear what they were doing. They took peripheral blood and passed it through a proverbial black box. It's Kevin mouth-warming, and serially exposed it to oxidative stress, and it did not work. Probably a good way to end that one. So therapeutics for ADHF with cardiorenal syndrome. So many drugs that are sometimes seemingly effective in individual patients, all of which fail in clinical studies. Same could be said for devices. Time to try something new. So that lets me segue into something new stuff. So this is our selective cytophoretic device. And what does that look like? It's a dialysis cartridge, right? So this is a self-processing therapeutic device which modulates neutrophil and monocyte kinetics in a low ionized calcium environment, achieved through regional citrate anticoagulation, right? So we give citrate when you do dialysis. You give heparin, but then the patient's anticoagulated systemically. So you give citrate because it binds calcium, makes the environment hypocalcemic. Clotting factors depend on calcium to do their thing. So if you get rid of the calcium, you don't clot off your filter, hopefully, and then you give the calcium back at the end, and you're not systemically anticoagulated. So this is the setup that was used in a number of experiments where it was actually done along with continuous renal replacement therapy. What I'll be discussing with you is doing it without renal replacement therapy. But what you see here is that blood flow in this setup at the top here is directed to the outside of these of the hollow fiber membranes in the filters. So it's sort of the opposite of what's happening in standard dialysis. So the blood is passing through with low shear forces, and it's shear forces that are similar to what we see in the capillary interface. And I think I talk about it. Well, let me just say it now because I don't know if I think I may have not made it clear in the slides. What's happening is that in this, in a hypocalcemic environment where the ionized calcium level is between 0.25 and 0.4, monocytes and neutrophils, and not cells of the adaptive immune system, but of the innate immune system, it's only the activated ones that have upregulated their integrins enough to actually bind to these fibers. So the thought is, the operating principle here is that you've got to get calcium levels low enough for this to happen. And this, in fact, not just binds these activated neutrophils and monocytes, but in fact, they deactivate while they're bound to the membrane, and then are released after a few hours back into the central circulation in an inactive state with some revved up apoptosis of those cells. So there's evidence that these monocytes actually shift from the classical and from the two inflammatory subtypes to the anti-inflammatory non-classical subtype. There's also evidence that tissue macrophages are reduced when one does that. That's been shown in CKD patients, 14 patients at Henry Ford with CKD who were on this for 6 hours. And it's also been shown in a dog model that I'm going to show you in a little bit. So this is showing leukocyte adherence to the selective cytopheretic device membrane. In panel A here, we're seeing, whoops, there we go, cells around each fiber. In panel B and C, we're seeing higher powered photos showing them bound again. And in D, while this is a little too small, I think unclear for you to see, it's pretty clear to see at least the neutrophils there, at least for me when I see it on a better slide. And this kind of goes through, I think, oh good, it's actually visible, what's happening. So you have the blood flowing outside and between the fibers at a low shear rate. Here's the red cells, whoops, go back up. Here's the activated lymphocytes with the activated, I said lymphocytes, activated leukocytes, monocytes, and neutrophils binding to the membrane. Here they are deactivating in this low ionized calcium environment, and then they're being released. This increased apoptotic rate downregulates activation. So there are a host of preclinical studies showing striking efficacy in pig models of hemorrhagic cerebral infarction, acute lung injury, and septic shock. I don't have time to go through all those, but I'll go through a little bit. And this was published in PLOS ONE. So what did Andy say? Not too shabby. So this is these are brain sections of a hemorrhagic stroke model in which thrombin is injected, and you see the sites of thrombin injection here. And what I direct your attention to, so these are animals that were treated with the SCD. This is an animal, this is an animal, this is an animal that was not. And what you see here is the clear differentiation of white versus gray matter here and all the way along in this graphic. And here it's gone because of the surrounding edema and infarction. And this is looking at that brain tissue. And what you see here is the activated neutrophils here in pink, and a relative dearth of them here with SED therapy. So not all that's been done, this is with pigs, there's actually people. So I'm going to talk to you about a randomized clinical trial. And there were some smaller randomized clinical trials first, but this is a larger one, comparing CRRT, and actually you had the option of doing any flavor of CRRT you wanted, to CRRT plus the SCD in ICU patients with acute kidney injury and at least one non-failing organ, so a SOFA score of 2 or greater, or proven or suspected sepsis. So that's how you got into the study. The primary outcome was 60-day all-cause mortality. The secondary outcomes were a number, but the two major ones were 60-day renal replacement therapy dependency or 28-day mortality. So you see the control therapy is you're getting CRRT alone with, again, citrate anticoagulation going in and calcium, administration going out. Or you're getting all that, but you also have the SCD in line, and you're not getting the calcium back until after you get the SCD. So the planned sample size for the study was 344 patients with 1-to-1 randomization, and it was terminated by the sponsor, Cytoferix, which is the U of M spin-off. I should mention David Humes, who was the head of medicine at the VA when I was an intern, and then head of Department of Medicine for the whole department at U of M when he hired me. Wonderful guy, great basketball player. So this is his company. They stopped it after 134 patients. And why did they stop it? Well, some of you may remember that there was a nationwide shortage of intravenous calcium. This is one of these crazy things that we have going on now, where things that are not particularly hard to make, but also unfortunately not particularly expensive, where the profit margin is low. There are often just single source companies, one company that does it, and if they're having problems with manufacturing practices or there's just not enough profit in there, we don't have them. So there was a profound shortage nationwide, and if there's any nephrologists out here, they all know about this. So what happened was the investigators were limiting the citrate infusion rates, and that's fine if you're okay with clotting off your dialysis cartridge more frequently and want to swap them out a bunch. And you can check how much clearance you get, and it costs you more money because you're going to use more dialysis cartridges, but you can probably effectively take care of patients with respect to just doing CRRT. But the whole premise behind how this thing works is that you've got to have low ionized calcium or it's not going to work at all. And they've plenty of work they've done to show that. So as it turned out, ionized calcium levels within the circuit tended to be higher than the target of 0.2 to 0.5. So in fact, of the 134 patients who had been put in the study, only 50 spent 90% or more of their time with ionized calciums of less than or equal to 0.4. So the primary analysis, of course, we got to follow the principles of clinical trials. So the intention to treat analysis, where you analyze things according to randomization, didn't show it anything, absolutely nothing. But a protocol analysis was performed on the 50 patients who actually got their ionized calcium down where this thing would have a chance to work. And here's what happened. So here we have 60-day mortality. So 11 of 27 people the control patients, 41% of them died, but only 3 of 19 or 16% died with the SED. Dialysis dependency went from 27% to 0. And the composite went from 56% to 16%. The 60-day mortality, while obviously profound, was not statistically significant, 0.07. Dialysis dependency and the composite were both statistically significant. In the post-hoc analysis, there was absolutely no mortality difference for controls who had an ionized calcium of less than 4 versus greater than 4. So just lowering your calcium to 0.4 without this device is not the cure for cardiorenal for acute kidney injury. But I think there was a clear efficacy for a signal in the SED treated patients who actually were able to follow the protocol, or the doctors were able to follow the protocol. So that you're not going to be able to go out and order this right now. There is actually, David's company raised $40 million, and there is an ongoing study of acute kidney injury, basically this study in the pediatric population. And why in pediatrics? Because of the orphan status. Right? You can cost less money to get that through, but this will be next. Okay, now let's talk a little about hearts. This is a study looking at reperfusion injury in a dog model where the circumflex artery is occluded with a balloon, proximally occluded. The occlusion was maintained for 3 hours, and then reperfusion occurs. Treatment with the SED is initiated 30 minutes prior to reperfusion and maintained for 2.5 hours. And this is just showing you what control looks like. You see the area of infarction there, and it's pretty reproducible. And this is showing you an SED treated animal versus a non-SED treated animal with over a third, or 2/3 reduction in the size of the infarct. And this is looking at troponin elevations in this model, and you see greater troponin elevations in the untreated animals. Those of you who work in heart failure are probably familiar with Tony Saba's model at Henry Ford. This is a model of repeated microembolization that results in a reproducible drop in EF to 25 to 30%. And this model has been very, very widely studied. Tony is the go-to guy for drug companies and device companies because results in this model have largely, with various therapeutic agents, have largely recapitulated what we've seen happen in human clinical trials. This cartoon is essentially showing that we did the same stuff as we've been talking about. They did the same stuff with a dog that had been rendered to have cardiomyopathy through this microembolization. And this is looking at acute changes in ejection fraction in 20 animals, 10 each. And you see here a rise in a dramatic rise in ejection fraction over the course of 4 hours with a beginning fall during the 2 hours of washout. Here are preliminary data. This is just 3 animals per group, where we're looking now at longer term effects. This was done as, and actually all of these therapies have been done, it's 6 hours on. Now most of the studies have been done as every other day treatment, which is how this was done. So 6 hours on, day 1, nothing day 2, 6 hours on, day 3, and day 5. Yellow is control. Blue is the SED, and this is change in EF. And you see a rise here of about 6 points in EF, going down to 4 and 5. And here you see really nothing happening in the control animals. This is out 2 days, 7 days, 14 days, and 28 days. And again, therapies at day, first day, day 1, day 3, day 5, depending on whether you use surgical numbering of days or medical numbering of days, I guess. And this is now looking at cardiac output, and same time, whoops, go back. Same measurement times, and cardiac index going from, this is actually index, not output, going up at day 2 with still sustained effect, at least out to about 2 weeks in those animals treated with the SED and nothing in control. And there was no difference in systemic vascular resistance or heart rate between the groups. So I'm going to give you a case, an anecdote case. So a 45-year-old man with long-standing systolic heart failure presented to the VA hospital in June 2012 with an 18-pound weight gain over the course of 2 weeks, history of diabetes, sleep apnea, chronic kidney disease, AFib and ICD, increasing shortness of breath such that he was unable to walk 10 yards, and increasing lower extremity edema. He was flogged the way we usually do. And he then gets transferred to the university hospital, where we continued to not relent. And his BUN and creatinine rose to 64 and 3.38 from a baseline creatinine of 1.5. TE was done showing, that should be a right heart cath, showing a wedge pressure of 30 and index of 1.4. This was David's slide. You can't trust a nephrologist to know what a right heart cath does. And those lousy hemodynamics were on milround. His EF is terrible. He's begun on CVVH with the SED 4 days later, and he's treated for 4.25 days with the SED. So now, remember, he's getting CVVH also. So there's 2 sort of striking things here. So first of all, note that he's only getting treated this far. Okay, so day 5 is only 1/4 day. Actually, I take that back. Day 4 is only 1/4 of a, yeah, well, think of it this way, yeah, day 5 is 1/4 day. Urine output is increasing, right? So here's urine output, despite the fact that he's getting CVVH. Like, who makes more urine when they're on CVVH, right? And then the SED is stopped, and now he's going into positive fluid balance. So interestingly, this is not just resulting in changes in kidney function, but actually changes in infiltration as well. And there's I wanted to show you a video, but I think I didn't bring the, I didn't link the files right, so I took it out of the slides this morning. But there's a nice video showing in a small animal showing sludging within the vasculature and resolution of sludging using this device. So what is clinical support for evaluating SED in type 1 cardiorenal syndrome? Just to summarize, so SED reduces death and the need for permanent dialysis in people with acute kidney injury in the setting of multisystem organ failure and or presumed sepsis among those actually receiving the therapy, right? The big caveat. SED acutely improves cardiac function in a canine heart failure model with the effect sustained for at least 2 weeks. And data that I have not shown you in CKD patients that I alluded to earlier, showing reductions in IL-6 sustained up to 2 weeks, and increased IL-6 is associated with decreased survival in CKD. So we're proposing an early feasibility study to evaluate this therapy as treatment for CRS in subjects with end-stage heart failure, otherwise candidates for an LVAD, but are precluded by kidney dysfunction. So the idea was we're trying to come up, where would be a place that we could study this? And, LVADs are just, they're a wonderful therapy for people who are sick enough to need one. Don't sign me up unless I really need one. But what they are absolutely spectacular for is as an experimental platform, right? Because we can get tissue from these people. When we put the LVAD in, we get the apical core that we can study. Sometimes you can biopsy people before that. Usually the next tissue you're getting is sort of after the LVAD if somebody goes on to be transplanted. Sometimes you get it for other reasons too at the end. But so it's a marvelous way for us to really to do studies that would otherwise not be able to be done. Here the issue is that these are folks who their trajectory in the absence of us being able to VAD them is pretty awful, right? So I will tell you that we are going to our IRB with this now, but I think we're going to have a pretty easy time because the upside potential of being able to get VAD in this circumstance is high, and the risk is very, very low because there have been millions of people whose blood has gone through a hemodialysis cartridge, and again, where these people are going in the absence is pretty clear. And then the other thing, of course, is that we're really at this point just looking for a short-term effect. The immune system is pretty complex, and as is as is the human body. It's sort of amazing that you can do things and that they work sometimes. And something as blunt as this. Seeing the long-term studies are obviously raise many more issues. So this is we're proposing a phase 2 single-arm, open-label, uncontrolled before and after study in 10 patients. The inclusion criteria will be a primary hospitalization for ADHF, potential LVAD candidate, and the 4 sub-bullets there are all the indications for destination therapy in the United States. With worsening renal function defined as a rise in serum creatinine of 0.5 or greater from baseline, and a baseline EGFR of 40 or greater, with the thought that we want people who are more likely to be salvageable. Cardiorenal syndrome is most likely explanation for their problem. Other acute kidney injury excluded by an independent nephrologist. A PA catheter in place because we want to do measurements and evidence of volume overload there. And then the exclusion criteria include exclusion criteria for getting bad therapy, things that might put you, really it's all about bad therapy, with the exception being the third to the end. We don't want people who are already perhaps too tough a nut to crack. So the intervention is this device. In fact, we're just going to use an off-the-shelf FDA-approved filter. Subjects will be placed on it for 6 hours of daily therapy for 3 consecutive days. So we're actually going to load a little bit more in terms of the therapy, given how sick these folks are. And then if subjects have had a favorable response, we can continue it for a number of more days. In part, that's to get more data. In part, it's because the logistics of actually getting insurance approval for a VAD and OR time, the rest. I'm sure we're not unique in that. Obviously, if the patient is not a VAD candidate, we would stop, or if there was a problem. And we're going to look at a variety of laboratory outcomes as well as clinical outcomes. So we'll be looking at urine output, filling pressures, sodium output, changes in inflammatory biomarkers, changes in circulating lymphocyte, leukocyte phenotypes. We're hoping that we are successful in some patients, in which case we'll have that apical core, and we can look at macrophage density, as well as, I should have written here, macrophage subtype. And we would be looking at the LV-APCs of people who get the device and go on to get an LVAD, people who just are standard LVAD patients who weren't in the study at all, and then if by some miracle some of the other folks get better, we don't get the SED, who are in the study, the control folks. We can look at them. We'll also be looking at people to look at the percentage of people who have successful outcomes with respect to creatinine and filling pressure and getting a VAD. And we'll look at sustained effects after they get a VAD as well. And then for safety, we'll look at obviously further rises in creatinine, hypotension, MI, and death. So in conclusion, chronic heart failure, CKD, AKI, type 1 and type 2 cardiorenal syndrome are inflammatory states. The present options for cardiorenal syndrome are largely ineffective. So in this group of patients who are at high risk for not doing very well, if we continue to do the things that we do, we're going to look to see whether this novel therapy that deactivates activated neutrophils and monocytes, frankly, the thing we think is playing a role here is not the neutrophils, but the monocytes, and reduces tissue macrophages, will allow us to successfully bridge these folks to VAD therapy and perhaps allow us to gain some important insights into the pathophysiology of cardiorenal syndrome. So thank you for being so kind to listen to me carry on.